moving quickly here. As Candice said, so we have three, it's really a casual discussion tonight in regards to important but casual discussion in regards to PrEP and PEP and kind of all things related to COVID and self-isolation and things out in groups. And it's meant to be a very candid, small group. And as Candid mentioned, so the only thing that is actually being recorded is not your video, but your audio. So we can ask questions at the end. What I'm gonna do is introduce each person. They're gonna give a little hello and what organization they're with. And then we have a flow of the conversation itself to kind of set the mood. So with that in mind, I will introduce obviously our physician here, Dr. Alex Del Rosario, and who's one of our panelists. And then we have Andy Ansel from Desert AIDS Project, and we also have Rob Fontanilla. I always want to put an A on the back end of that, from Borrego Health. And so let's have everybody just give a little hello. Dr. Del.
Hi, I'm Dr. Alex Del Rosario, and I'm at Eisenhower's North Palm Springs Clinic. And I see now I just checked my list, 669 HIV positive patients, and we have about 500 PrEP patients. So.
Fantastic. Go ahead, Rob.
I'm Rob. I work at Borrego Health. I'm a physician assistant, and I specialize in HIV care, which also includes PrEP. Transgender care, hepatitis, MAT, which is the opioid assistance program. And that's about it.
That's a lot. And then Andy.
Hey everybody, my name is Andy Ansel and I manage the PrEP program here at Desert AIDS Project.
Fantastic, thank you guys so much. I'm gonna go ahead and mute myself, and Dr. Del, if you'd like to share your screen and start us off, we'll go with that. And then when you're done, we'll unshare that and we'll start the conversation.
Okay, so what I was going to do is just, let me see here if I can do the share screen here. There it is. And I was going to just do a few quick slides to show about PrEP and the current state of the pandemic where we're at, to just start the discussion off. So is that screen showing up now? Okay, great. So there's been some recent papers that have shown that either HIV positive patients on antiretroviral therapy or guys taking PrEP may be at a decreased risk for COVID. And there's been some papers that have come out with that. I just wanted to show two of the most recent ones. So this is currently just right now, just the state of where we are. This is data from the CDC website, which takes a look at the cases over a 7-day period. And it shows how the United States is doing. You can see here, California is a dark color. When you see it down there at the bottom, that looks like we are in the worst area as far as the number of cases per week. That's because California is the most populous state in the union. We have a lot of cases. If you take a look at it from a different way of looking at something called the incidence, what percentage of people have positive, you look at it now, California is in the low end. We're the second to the lowest. We're actually doing pretty good. So our incidence is actually pretty low. And the states that look bad are the Midwestern states. If you look up there, this is actually from yesterday, it's actually gotten worse. Idaho is now part of those red states up there, orange states, they're all red states. They actually are red states, but now they're the states with the highest incidence: Idaho, Montana, North Dakota, South Dakota, and you can also see there Wisconsin. So all of those states actually have the highest incidence per 100,000 of COVID. So it depends on how you look at the data, who's worse or not. And for right now, as of yesterday, for California, we only have about 75 cases per 100,000. Some of those redder states, Idaho, Montana, North and South Dakota, and Wisconsin, have up to 45 or 50 cases per 100,000. So they're much worse than us when it comes to that. And then so you can go to the CDC website yourself and take a look at this. And like I said, it updates it on a daily basis. This is just taking a look at Riverside County in comparison to the others. This is the number of hospital bed infections with COVID. Los Angeles still leads, but Riverside County, we're number 6. So we're looking not so good because our rates have gone up, but this is hospital bed infections. And then if you look at the pandemic worldwide, there's the CDC website. I was going to show that, but I couldn't figure out how to share that part of my screen. So I'm just going to go over, this is just the enemy. This is COVID. That's the virus. It looks a lot like HIV viruses because all viruses look alike. This is just an explanation of the replication cycle. I'm not going to go into any detail about that, but and the first part of it, where it enters the cell, that's where the HIV medications and the PrEP medications and the retroviral medications specifically for COVID, they all work about the same place. So that's why there's some thinking that coronavirus is a retrovirus, HIV is a retrovirus, and the medications that we take for PrEP and HIV may also work for coronavirus. So there is some scientific underpinnings for that. And then to just talk about this is the Spanish study, which showed that HIV positive patients on therapy may actually have a lower risk for COVID. When we first started with this, we thought HIV positive patients would be far worse off. But this study took a look at Spain, and they took a look at over 77,000 HIV positive patients, and they determined which one of them had COVID. So this is actually COVID proven by that horrible nose swab that they have to do. And of the 77,000 patients, they found 236 patients actually had COVID. Low incidence, that's 0.3% of the HIV positive population. So that's actually lower than expected. When you compare that to the general Spanish population, it was only 0.24% of the actual Spanish population. So the HIV positive guys had a lower than expected incidence compared to the general Spanish population. That's why they thought, okay, the HIV medications may actually be protective. And of those patients, they broke them down into smaller groups who required hospitalization, who required ICU admission, and who actually died from that. And they actually show they show the breakdown in the study. And this is the big comparison here at the top of the guys who are on HIV therapy and antiretroviral therapy are shown here on the left hand of the slide, and the general Spanish population on the right. So this shows the incidence, what percentage of HIV positive patients had. So this is 30 cases per 100,000 HIV positive patients had COVID who were on antiretroviral therapy, compared to the general Spanish population, where it was 42 cases per 100,000. So HIV positive patients actually look like they did better than the general population, and they had lower incidence of COVID. But the healthcare workers had a higher than expected incidence of COVID. When you subtract out the healthcare workers, that's the 33 cases per 100,000. So HIV positive patients did a little bit better if you take out the highly infected healthcare workers. So there is some supporting evidence that there may be some lower incidence in HIV positive patients, but only by a little bit. And when you compare the backbone of the Del Amo study, the one thing that came out is it looks like good old-fashioned Truvada might actually work better than Descovy as far as who gets COVID. This is just taking a look at the total number of patients who were on antiretroviral therapy. The more of them were on the new Descovy, not as many of them were on the old Truvada. Some of them were on Epsicom as a backbone, and then some of them were others, but that's the total number of patients. So when you take a look at that, their breakdown just about even, a little bit more people on the new in green Descovy, a little bit less than a quarter on the old-fashioned Truvada. But when you take a look at who actually got COVID, the numbers are much, much smaller. And so that's the important part about the study, is that there's not a whole lot of patients. It's only about 236 patients, so it's not a whole lot in the study. But when you take a look at that, it looks like Truvada, the number there is much smaller for Truvada. So fewer patients who were on Truvada actually came down with COVID. So it looks like Truvada actually performs better in that regard, and that fewer patients with Truvada got COVID. Relatively more patients on Descovy got COVID. So that was one of the things that the authors pulled out of this, that good old-fashioned Truvada might actually work better as far as protection against COVID. These were the number of patients who were actually hospitalized with COVID based on whether or not they were taking Truvada or Descovy or Epsicom. And you can see that there's fewer on Truvada that were actually hospitalized, the most actually on Descovy. No patients on Truvada were actually admitted, 0 to the ICU, and 0 on Truvada actually died in this study. relatively more died on Descovy, which is a little bit unusual. Descovy exists almost entirely inside the cells. Truvada exists at high levels in the plasma, and that may actually be one of the reasons. There are some other theories as to why that may be. There were some criticisms of this study because it was such a small number. But the main points of this, and then this is the breakdown. It's a little bit of a complicated slide, but basically the important thing that shows is that no one who died was on Truvada. That was the basic list. The main points that HIV positive patients are not at an increased risk for COVID, but they may actually be at a decreased risk, and that the Truvada may actually perform a little bit better than Descovy. That was the main points from this study. Then because of this, they thought, well, what about the guys taking PrEP? Because they're also taking Truvada and Descovy. Do the guys on PrEP have a lower risk of getting COVID? And they just recently published the results of a study by Dr. Ayerdi, who took a look at just that point. And it was came up with a little bit of a different result. This was done at one clinic in Madrid. The larger study was done at over 60 different clinics. This was done at one clinic. And they looked at 250 gay men who were not on PrEP and 500 gay men who were on PrEP. And most of them were on the old-fashioned Truvada, less of them were on Descovy. And the big thing about this result is that they actually didn't see much of a difference. When you take a look at the bottom line study here is the number of people who came down with COVID. There were fewer people who came down with COVID who weren't on PrEP, more people who came down with COVID who were on PrEP, and that was the conclusion that there was no protection from this study. One of the criticisms is that the people who were taking PrEP didn't do a really good job taking their PrEP. There was only about 2/3 of the people who were really compliant with their PrEP. So one of the criticisms is that maybe this really doesn't reflect people who actually are taking PrEP because they were not so great about taking their PrEP. It looks like that the people who were taking their PrEP had fewer symptoms of COVID, but they said that was not statistically significant in this study because there were so few people. And it looks like the people who were taking PrEP had a shorter duration of their symptoms of COVID compared to the people who weren't. But again, that was determined not to be statistically significant. But again, the problem with the study is it was much smaller. So the two big things from the study is that the much larger study showed some suggestion that at least HIV positive patients who are taking antiretroviral therapy are not at an increase for COVID, but may actually be at a decreased risk. The question is whether or not does PrEP help guys who are HIV negative from preventing COVID. We have one small study from one clinic that shows that it probably doesn't, but again, it was a very small study, and the guys who are taking their PrEP were not really good with taking their PrEP. So the bottom line is we need more studies. So that was the only two studies I wanted to go over. And so I will unshare my screen and get back to just the regular discussion.
Great. So with that in mind, who would like to start? If there's, well, first of all, if there's any questions on that, or if there are any burning questions that you would like to, and if not, I'll turn it over to Rob to kind of maybe say a few things about Borrego and what you're doing with your care services, and then we'll go to Andy as well.
Okay. Well, in regards to COVID or PrEP or both or?
Both, yeah, combination, whichever you feel.
Okay. So at Borrego, we're still treating PrEP. What I'm finding just in my practice is I have a mix. I have people who are truly doing social distancing and not like having either planned or unplanned sex with people they don't know. And so for some of those people, they've just stopped taking PrEP. The ones that are truly not engaging in sexual activity during this time when some people are social distancing. And so for those people, we've just had them stop, because if they're not sexually active, they're not interacting, they're not putting themselves at risk in terms of sexual activity, there's no reason for them to continue to take their meds. So they've stopped. We do have a couple of people, well, not a couple, the other handful of people who are still engaging in sexual activity with known and unknown sexual partners. And so for them, they're continuing with PrEP, and we just treat them as if we would if it was a non-COVID time. And so we're still doing the every 3 month screening for STDs and HIV. In terms of COVID, fortunately, there's a ton of commercials about, you know, the partnership with the Indian tribe, and so they do testing for the community out in Indio. But then each of our different clinics are doing the drive-up nasal swabs, and so at first, COVID testing could take up to 2 weeks to get results, and now literally we're getting them either the next day or 2 days after. And so when patients come up, whether they're on PrEP or not on PrEP, or an HIV patient or a trans patient, we set them up for drive-up testing for nasal swabs. We swab them in their car. They don't even get out. And we do it during specific times so that the person doing the swabs is in PPE, personal protective equipment. And then we give them their results back, usually through phone or teleconference. And that's kind of the MO that we're doing. And I'm just finding that there's two groups of people who stay on PrEP and are still sexually active, even during COVID, and those who are not participating in sexual activity with others during COVID.
Great, thank you. We'll have some more questions in a minute, but we'll jump to Andy.
Sure. Well, so obviously DAP, when COVID first started really taking a toll, we converted our doc sexual health clinic into a COVID triage clinic. So that clinic is still operating, and they're still doing testing out of there. And we found, or I found personally, that there was a much diminished need for doc services in the first couple of months of the epidemic. So people weren't coming out of the house, they weren't coming in for testing, they weren't coming in for HIV testing. But I think that what I saw personally in managing the PrEP program here was that March, April, May, everything slowed down. We transitioned to virtual appointments for everybody that was on PrEP. So, you know, we tried to do everything as virtual as possible. Then towards the end of May and the beginning of June, we started seeing an increase in the level of syphilis cases that were being diagnosed and other STIs that were being diagnosed. And in the months of June and July, the number of post-exposure prophylaxis clients that we had almost doubled. So, you know, we were generally treating 3 to 4 post-exposure prophylaxis patients a month, and that jumped up to 8 or 10. And a number of those individuals reported that they had been on PrEP and had stopped PrEP because of COVID, because they weren't planning on being sexually active, and then found themselves in a situation where they were sexually active and they had been off PrEP long enough that they needed post-exposure prophylaxis. So, you know, as we've been working with clients here, and, you know, everybody wants to ask that question, well, should I continue my PrEP? I kind of say it's not really my job to tell you, yes, you should or shouldn't be on PrEP, but the whole idea behind PrEP is that you are prepared in the case that you're going to be sexually active, right? Lots of clients have come in and said, well, I wasn't planning on being sexually active, and, you know, and then I found myself back on an app, or I found myself on a site. And I think it's an unrealistic expectation for those of us working in the prevention field to think that people are going to be able to socially isolate for 18 months. I mean, I think now we've moved into this phase where COVID has normalized slightly, and people are returning to more of the activities that they did maybe in the first couple of months of the epidemic, when everybody was really stringent about their social distancing. But I think that we're seeing a little bit of COVID fatigue in terms of people's activity increasing now that we've been in COVID for a few months.
Exactly.
Yeah, and so Dr. Del Rosario, is that what you're seeing within your clinic and your client, customer, or patient base?
You know, as Andy was going over that, I was shaking my head a lot, because that was exactly what we were seeing in our clinic. Yeah. For March, April, May, our STD screening almost stopped because people were so terrified of getting COVID. There was really nothing going on. And even my courier noticed, because we pick up our STD screening samples every day. And the courier said, hey, you're not sending anything in. There's a pandemic. I might lose my job. And so I said, well, I would send something in if people are doing anything. But by about May, June, the single guys had had enough. And they said, I'm either going to have sex or going to die because I can't stand it anymore. And so by end of May, beginning of June, our STD screening started picking up and we started sending more samples in. My courier kept his job, so he was happy. But we didn't necessarily see a big bump in the COVID cases, and the vast majority of my practice is HIV positive or PrEP. And that was also around the time that the first article, that the Delamo article came out that showed that HIV positive patients on at least 2 reverse transcriptase inhibitors or the antiretroviral therapy may have a lower risk for COVID. And I was showing that with my patients, and basically I have, like I said, over almost 700 HIV positive patients. I've only had 9 confirmed cases of COVID among them, so still very little. So the Spanish study confirmed what we were seeing here in Palm Springs, is we weren't seeing that many COVID cases. And even in Eisenhower's own COVID ward, we only have admitted a handful of HIV positive patients. The nurses were all commenting on the words like, we were expecting a lot of HIV positive patients. There aren't any because they're just not getting sick. So there seemed to be some evidence that the antiretroviral therapy might be helping. And that's actually what I was starting to tell the PrEP guys that said, there may be some evidence that PrEP might be helping you. But then again, that's what got the PrEP guys to go back on their antiretroviral therapy for their Truvada or their Descovy, because they said, okay, if that helps protect me against COVID, that's a reason for me to take it. And it turns out the guys who were on PrEP who got COVID, most of them had gone off their PrEP. But again, this new study by Ayerdi seems to show that possibly the PrEP does not help reduce for the guys who aren't HIV positive. But again, it was a very small study, and the compliance rates for them were not very good. So we need more studies to show what the real deal is.
Thank you.
Yeah, and I think that I saw that as a trend too, as people were wrestling with this idea of, should I stay on PrEP? Should I stop my PrEP? There were enough articles floating around there about the possibility that antiretrovirals may provide some level of protection, that I had a fair number of people who said, well, I'm not sexually active, but I'm going to continue on my PrEP. If there's even an outside chance that being on PrEP might help reduce my risk of COVID, then I'm just going to stay the course and I'm going to continue on my PrEP.
And our practice too is very similar to Dr. Del Rosario, where I don't know what our actual HIV consensus is, but very few actual positive cases and only 1 hospitalization. So it's, the HIV patients didn't really present much with COVID, at least in our practice as well.
And I think that's what I see articles on that, and that's what I hear from other physicians, and especially the Eisenhower world, and Dr. Del Rosario is on the forefront of it, but others are saying the same thing. We just don't, in the communications I receive from people in the community asking about healthcare, they're asking about PrEP, they're not, and you start to wonder, where are they? Or is that because they're active? I mean, I hear of tons of pool parties have commenced again, all those kind of things that were going on, but you're hearing the STI kind of break out, but you're not hearing necessarily a lot of COVID, tracing from that.
No, and I think so far, at least the 9 HIV positive patients who had COVID, they actually had relatively mild disease, and I would say more mild compared to the PrEP guys who if they were still on their PrEP and they got COVID, they had a little bit more severe disease. And again, that's supported by some of the research articles that say that the reason people turn bad in COVID when they get infected is because they have this hyper-inflammatory response. HIV positive men tend to have a slightly blunted inflammatory response. So when they get COVID, they tend not to get as sick. The average time of illness for my HIV positive guys was only about 2 or 3 days that they were sick, and that they tended to feel pretty good by day 4. The guys who are just on PrEP, they have a normal immune system, so they can launch the inflammatory response. So on average, the PrEP guys were sick for about 7 to 10 days, so a little longer than the HIV positive guys. But the vast majority of our guys recovered. So.
Good. And another question, I know on your previous, you were talking about, well, actually, we have two different questions, but I'll take the first one. Are HIV patients more careful about social distancing? Do you think from just in discussions you're having with your patients?
I think definitely early on they were, because when this first started around, March, they were incredibly careful about the social distancing because they thought, oh my God, this is another pandemic. We've been through this before. And, the guys were coming into the office, they were all wearing their face masks. They were all, washing their hands. They were using the hand sanitizer. So they were all being very, very careful about it. And that is one of the things that they said in that the initial Del Almo study, that one of the reasons that H positive patients might have a lower incidence of COVID is because they do a really good job with social distancing. They all believe in masks, they believe in science, they do what they're told. So that may be one of the reasons why we're seeing less in the HIV positive patients. And most of my patients have said, face mask is like a face condom. We've been through this before. We've stared down the barrel of a gun. We know what to do. And so they actually do the things they're supposed to do.
Yeah, and I think cleanliness is just part of the culture, especially if you're HIV positive. You're always a little hyper aware of that anyway, I think. Another question is in regards to any thoughts on taking vitamin D and or zinc as preventative for COVID, or anything that adds to the mix with those kind of items? You see a lot of that in people. There's none on the shelf in many places that I noticed.
There's a lot of stuff that's out there. And again, as far as just for the example for the PrEP versus the HIV positives, there's a lot of articles. You have to plow through them and look close at the statistics and the details. I was talking with other my colleagues about some of these articles. Some of them were quoting papers that have maybe only 20 people in them. The reason I picked the Del Almo article is because it took a look at 77,000 HIV positive guys, one of the biggest articles. So you have to be a little careful about where the source is, what their statistical analysis is, what they're looking at. And unfortunately, who is paying for the study is an important thing too, to find out who's paying for the study, because unfortunately that can introduce a bias.
We do have a medical question, well, all our medical questions, but in regards to the Descovy versus Truvada, because I know in previous lectures we've talked about people who have instance of kidney issues and that kind of stuff, and so they went more on the Descovy. I think I have it correct, versus the Truvada. But now if they're on Descovy and they're not having any issues, is there enough in the results that you were talking about to maybe move back to Truvada, or if it's not working as well, or is it just individually based?
Based on the Del Almo study, there is some suggestion that Truvada performs better than Descovy. I'm sure that most of the study authors there from there, and also HIV practitioners who have commented on the results of the Del Almo study, so they wouldn't recommend any change in therapy based on that one study. It is a relatively small number of patients, so we need more studies to back that up. Having said that, we are actually getting some pushback from insurance companies about covering Descovy, because Descovy is brand name, Truvada is now generic. So even some patients who have previously had Descovy covered, their insurance is saying that, no, you have to take Truvada now, the generic version, and only if your kidneys go bad, then we'll cover Descovy, basically is what they're saying. So the Del Almo study just gives me a little something to tell them, like, hey, well, okay, you have to go back on Truvada, but it might perform a little bit better than Descovy as far as reducing your risk factors for getting COVID. There's some suggestion of that, but again, like I said, these are just two small papers, one much smaller than the other, but there is some suggestion of that. So at this point, I would make the recommendation based more on the scientific evidence. Are they having kidney problems or not?
Yeah.
And again, one of the things that one of the critics of the article brought up is that the Truvada may have performed better because the people who are taking Truvada are younger and healthier and have normal kidneys. The ones who are taking Descovy may be older and have more kidney issues, and then belong to a higher risk factor for complications for COVID.
Okay. And so Rob and Andy, are you seeing, I guess, in the same thing with Descovy versus Truvada, is Truvada the typical go-to, like when somebody comes in and they want to go on PrEP, is that's the main course? I would assume maybe Truvada, especially now that it's generic, which I did not realize. Are you seeing that within your organizations? How do you, Rob?
I think, well, for our organization, because we have such a large transgender population, and Descovy is not recommended for those people born female. So that's where we're seeing, that's where I'm seeing most of the Truvada being used, but almost everyone else is Descovy. So it's just the trans men that were born female.
And our clinic staff pretty much adopted Descovy when it came out. I mean, I think some of the rationale behind that was, you know, we have an older gay population in Palm Springs. You know, I'm 2 months away from the 55 and up bubble on the filling in on the form, so I could totally relate. But I think that was the thinking that, you know, with the reduction in possibility of side effects for kidneys, that our providers went with Descovy. But I will echo what Dr. Del Rosario was saying, and we're seeing an increasing trend for making it more difficult for clients to access Descovy through their insurance plans. It took about 3 to 4 months for the insurance companies to start to catch up with the fact that Descovy was slightly more expensive. It was the newer drug on the market. And we're running into, as a PrEP navigator and working with other PrEP navigators, we're running into that is more of a problem where the client gets a prescription for Descovy and goes to the pharmacy and can't get it filled. So I think that's only going to be a trend that increases, especially now that there's generic Truvada on the market.
Yeah. So speaking of the trans population, and for all three of you, how does PrEP work within someone who's on hormones, either from F to M or F to A, you know, whichever direction they're going, and they're on a hormone treatment plan? Does PrEP, I would assume, to your point, PrEP works differently with the hormonal system?
Well, the main differentiation and why Truvada is used for the trans men, for those that were born women, is just because it wasn't studied. So it had nothing to do with hormones or anything like that. So.
Okay.
In the trans patients that I treat, we haven't really made a distinction between that. We've been trying to use the Descovy, as you know, Andy had alluded to, because it over the long term tends to be more kidney friendly, tends to be more friendly to the bones over long term. It spares the Fanconi syndrome that can occur with Truvada. We haven't really made much of a distinction for that. Most of my trans patients are actually in monogamous relationships, so they're not taking PrEP. So it just depends on their own individual circumstances. In the ARD, they did include some trans patients in that PrEP study, but there were only like 5 trans patients in their study, whereas the vast majority were cisgendered gay men.
Yep. Okay. Naive question for myself is, so if somebody has been on PrEP and goes off, say during the COVID time, it goes off for 3-6 months, goes off for a lengthy period of time. Is it as simple as starting back up if they decided to delve back into their, you know, their cabinet or their med box and say, oh, I'm just going to start this weekend, you know, or what is the protocol from each of you? You know, how does that all work?
The actual protocol is they should be rechecked again in case they had, you know, some unprotected sex or a potential exposure for HIV. We need to make sure that they're HIV negative, and then you go back to on the 2013 guidelines and you check them every 3 months.
I think that the challenge that we run, or that I run into as a PrEP navigator, and I'm sure the clinicians run into also, is that people have access to this thing called the internet, and they go out and they read lots of things right on the internet, and they think that now they are an expert about PrEP. Sometimes the message that I always try to hammer home is, if you've stopped your medication, make sure that at the very least you get an HIV test before you restart, right? I mean, at the very least, you should really go in and get checked and screened, but at the very least, get an HIV test before you restart your PrEP medication. But I think the incidence of people stopping and starting on their own is probably a lot higher than what any of us know.
Yes,
unfortunately.
I would agree with that. I think one of the things a lot of people are doing too is stockpiling their PrEP as well. which I guess is good because if their insurance status changes or something, then they'll have a continuation of their medicine. But I know that for the ones I've talked to who have stopped taking their PrEP, they're still filling their PrEP.
And that is
Yeah,
a good. Go ahead,
commonly
Jose.
what we see is that they will miss their PrEP follow-up visits, but they're still filling their PrEP. The excuse lately has been because they want to, avoid coming to the office because of COVID. That was even going on before COVID. And then the biggest issue for us was getting them in time, a timely manner, to get their appropriate STD screening done and to making sure that their kidney function is still normal, especially if they're on the older Truvada. So those were the primary issues.
Mm-hmm.
And are you finding with insurance? I know for somebody, as you said, the stockpiling. I mean, there's many people right now who, a couple of friends of mine who were on PrEP, have stockpiled, and so they're feeling pretty good and hoping that they're going to get another job, but their medical insurance status has changed. And so, what is each of the organizations are a little different. So if you could kind of address the access to healthcare for someone who, say, is uninsured. I had an email this week from a gentleman who just is transitioning to town here from I think Wisconsin, and general site is a 46-year-old gay male, uninsured, and is wanting to go on PrEP. And his email to me was, "Where should I go?" And
So
yeah, please, Andy.
I don't know if the clinicians mind if I jump in on this one, because this is more my lane, the benefit
Exactly.
navigation stuff. I mean, it always comes back to a question of how much money does an individual make, or if they're making any money, basically. So we're lucky enough to live in a state that has a PrEP assistance program in terms of paying for somebody to access medical care for PrEP. It's for a single individual, it's basically $64,000 per year. So if a person makes that or below, they're eligible for the California PrEP Assistance Program. They'd also be eligible for pharmaceutical assistance through Gilead to pay for their medication. It's a very rare occurrence that we run into a client that we're not able to get PrEP for at little or no cost. I think the barrier is that people don't always realize that there are support programs out there to help defer the cost of the medical aspect or the actual price of the medication itself. And so that's always the challenge I work with lots of clients who come in and we get them set up and they're like, well, I never thought I could afford it. So I would have been on PrEP a long time ago had I known that there were support programs that would help pay for it.
Yeah. And at Borrego, there's a program, it's called sliding fee. So it depends on how much a patient makes. And depending on their income, it can either be free or up to $75 for the visit, which includes lab testing. So monitoring the HIV blood tests, STD tests. And then just like DAP, the Gilead program is quite generous. And so we're able to get quite a few patients signed up through their patient assistance program.
Great. And then Dr. Del Rosario?
At Eisenhower, I always leave that up to the billing people. We are more of a private insurance and Medicare. Medicare is pretty easy, but for those patients who have lost their insurance, and unfortunately we're seeing more of that because of the pandemic, there are other places where they can get their care. Their office visits and the labs are usually what ends up costing them money. So if there is a place where they can get their care that has those services covered and can then more importantly cover the very expensive PrEP medication. So oftentimes they have to actually leave the Eisenhower system to do that.
Yeah. Very good. I know. Thoughts, questions? I mean, we have other things going on, but thoughts and questions from any of the participants on the call?
I would just, and again, as as Andy had saying, and the others were saying, is that, if you guys are on PrEP, I would just continue on it. Just make sure you get your kidney function monitored, your appropriate STD screening done. Yes, there are some studies that are yes, some studies are no, as whether or not it helps protect you against COVID. We still want you to do the good mask wearing, social distancing, keeping up with the good hygiene issues, and then try and go about your life as you can. There's a lot of more psychological, psychiatric harm from the social distancing, and you're being very extreme about it, and social isolation. We still want you to reach out to people, and if you're going to be engaging in sexual activity, definitely you should be back on your PrEP. So.
Yeah. And on STI screening, I know I'm very familiar with obviously DAP and Eisenhower's, but Rob, can you talk, and then each of you tell us a little bit about that process? Someone who wants to have that kind of component first, so say, hey, we need to have an STI checkup as well.
Okay, so the question was, what is the process of?
Well, what does Borrego have? Do you have a walk-in clinic? I'm not sure exactly what you have in the sense of someone who's looking to have that, so they, for their inroad to kind of like, hey, I want to do an STI check, I want to go on PrEP. What does that entail?
Yeah, so for patients who enter the Borrego Health system, usually they sign up as Borrego being the primary care provider. And so once they do that, then they're signed up as a patient. And from that point forward, we just take care of them holistically. So that includes blood test, urine test. If someone specifically comes in for STD testing as well as PrEP, then we'll focus that on their first visit. But as time goes by, and if we're able to incorporate more holistic healthcare for them, that's great. For example, like diabetes screening, thyroid checks, cholesterol checks, that type of stuff. One of the things about Borrego, especially in the desert, is that there's a handful of different clinics. The overall umbrella of Borrego Health, quite honestly, is family practice. But there is a division within Borrego Health that specializes in the LGBTQ community. And that would be the Stonewall Clinic over in Cathedral City, and then Desert Hot Springs Specialty Clinic in Desert Hot Springs. But a patient can go to any of the Borrego clinics, which are in, for example, Coachella, Mecca, there's a women's clinic in Palm Springs, Desert Hot Springs, for regular family practice, but they can also access one of the specialty clinics if they desire to get their healthcare there, for not only just PrEP and STD testing, but just general family practice.
And Andy, can talk about
sure.
The doc?
Yeah, I mean, our goal as PrEP navigators for anybody who comes in and wants to get PrEP is to try to get PrEP for them at little expense or free, if at all possible. So here at DAP, we do operate a sexual health clinic called the Doc, which operates both on a partial walk-in and appointment basis. The one positive that I will say for the Doc and PrEP, it goes back to Dr. Del Rosario talking about people with insurance and out-of-pocket costs for the medical side of PrEP. So whenever we talk about PrEP, there's the medical side, there's an office visit and labs, and then there's the cost of the medication itself. And what we're able to do at the Doc is we just charge a flat rate fee. So for example, a PrEP initial appointment, so to see the doctor and to get all the required lab tests done and get a prescription is $125 for an initial appointment. And then the 3-month follow-up appointments are $25. For people who have insurance, they may have a high deductible with their plan, meaning that the labs and the office visits and everything are going to be applied towards their deductible. So they're going to be looking at hundreds of dollars of expense. And that's one of the things that we help walk a client through, is we help them understand their insurance costs if they were to use their insurance, if they were to just come to the walk-in clinic and access PrEP that way. I mean, obviously a client is going to be better off getting PrEP in the setting of a primary care physician or a primary care setting, because that they're going to be able to get all of their other healthcare needs addressed at the same place. But for some individuals who are on a tight budget, it comes down to a matter of money. And so our goal is always going to be, how can we get this for you for free? And if we can't get it for you for free, how can we reduce the costs as much as we possibly can.
Great, thank you. We did have,
Yeah,
yes,
there's
please.
a question up there that didn't get asked yet, so I thought I'd just chime in. So Dr. Del Rosario mentioned kidney damage. How prevalent is kidney damage with Truvada?
Generally, we see it in the older patients. So for the younger people on PrEP, if you're under, say, 50, we tend not to see a whole lot of it. The problems would tend to be when we have our older patient population here in Palm Springs. So the more times we see it is if you're over 60, 65, there's a general decline in kidney function starting about age 60, 65. And then if you're one of those 65-year-olds who need to pop an ibuprofen or a naproxen once in a while for your osteoarthritis, your shoulder, your knee, those are the guys who we sometimes have to take off of their PrEP, off of Truvada, because it's causing problems with their kidney. That's why we would then try and switch them over to Descovy, which is friendlier to the kidney, to see if they can be accommodated with that. The only problem is that once they hit 65 and Medicare age, Descovy is not as well covered on Medicare, and that's when we have to enlist the services of Andy to try and get their PrEP covered.
And it is a very valid statement, that last statement. It is humorous, but what it does is, and the reason we come together tonight and ongoing, is that the three organizations, especially here, Desert AIDS Project, Eisenhower, Borrego Health, all work very collaborative and closely together, especially in the HIV component of the world and our PrEP and PEP here in our valley. And so, which is a great thing, because I know when we've had individuals coming through the clinic, and then, as I said, the individual I was referring to earlier, I immediately, forwarded on so they could immediately get the care and some advice, and be able to talk to someone who could guide them appropriately. And if it's someone outside of our system, we thankfully, it's all about healthcare first, and how it all falls out later on the other side. For we're not pushing a primary care physician. We're just trying to get you into healthcare.
No, absolutely. I mean, when we help our clients review insurance, we always look, there are certain places that we look for primary care providers to see if they are considered in network for them. And it would be, Eisenhower, Borrego, and DAP. And we often have to refer somewhere else because we're not considered in network for their insurance or for whatever reason. So that is, definitely the fact that we're all collaboratively working on this together is very helpful for all of us.
All right, any questions from attendees or anyone that would like to ask some questions of the providers that we haven't talked about, or that have a burning desire to ask even another question? You have three fantastic individuals that would be able to answer a lot of different areas. Going once, twice. All right, no additional questions. I will say that our the next lecture we have coming up with the LGBT Center will be on November 4th, and it will be on managing sleep during stressful times. We thought that would be a perfect place as the day after the election, since we all will be anxiously sleepless and God knows what else. So with that in mind, that'll be our next lecture with the LGBT Center. And I really appreciate Rob from Borrego Health and Andy from Desert AIDS Project, and of course our Dr. Del Rosario from Eisenhower, and the LGBT Center for allowing us to participate in these twice, if not three times a month, especially during our COVID world in the summer.
Yeah.
Or as
Thanks
to say,
so much. I learned a lot tonight, that's for sure, that I didn't know before this started. So thank you to all of our health providers for all that wealth of information that you gave us tonight. We really appreciate it.
Any last thoughts from any of our speakers?
Besides, stay safe.
I know, stay safe.
And vote.
And vote.
And vote. Yeah, stay safe and vote. Absolutely. Yeah.
And
Thank
drop off at City Hall.
Yeah.
All right, everyone. Thank you so much. Really appreciate it. And we'll hope to see you soon.
Thank you so much.
Right, bye-bye.